much yet. We're going to look at the sub-analyses and, well, the ATTRACT data, the original ATTRACT data, to look at how that can inform us about which patients would best benefit from endovascular treatment. So the ATTRACT trial was published in 2017 now, so quite a while ago in the New England Journal of Medicine. At the time, it was awaited as the pivotal trial to provide definitive evidence for the benefit of endovascular treatment of DVT. It didn't prove to be true. 691 patients were included of 27,000 screened. So we can see the first issue there. There was a very low recruitment rate, likely reflecting lack of equipoise amongst recruiting physicians. The patients were then randomized 1-to-1 to endovascular thrombus removal with anticoagulation versus anticoagulation alone. The modalities of endovascular treatment were principally angiojet and trellis, given this was a while ago. The mean thrombus removal in the study in the endovascular group was 74%, and the headline finding that most people talk about is basically the rate of any PTS was approximately the same between the groups, 46.7 in the intervention arm and 48.2% in the conservative arm. And this was combined with a statistically significant higher rate of bleeding in the endovascular group. It is important to sort of contextualize this study in that the patient recruitment, the idea of this study was endovascular treatment was offered as a first-line treatment for essentially any DVT. So symptom severity, response to anticoagulation, thrombus burden, typical things we use in our patient selection were not study entry criteria. And it included many patients who are not typically referred for intervention. And this is a quote from the study author. So the whole point of the study, we were not seeking to validate the use of interventional treatment as salvage therapy. Rather, should it be extended as a first-line treatment to all DVTs? So this is the results of the study, and some of the things to pick out. Over half of the patients in both groups had a Valalta score of less than 9, so that would indicate mild or no PTS, and I don't think any of us would countenance treating patients with essentially no venous symptoms. 58% of patients in the pharmacomechanical group required a lysis infusion with a median duration of 22 hours. So we can quite clearly see how the bleeding signal can be explained, and there was a low stenting rate. So in summary of the original data, extremely low randomization rate, inclusion of patients with mild or no symptoms. The primary endpoint was PTS or no PTS, so a very binary endpoint. And again, we know in venous intervention, you're often not looking for perfection, you're looking in improvement in symptoms. There was a large proportion of FEMPOP DVTs included, which historically we wouldn't treat with endovascular treatment, 43%. There was a high rate of loss of follow-up, particularly in the anticoagulation arm, so 68% of patients only completed 24-month follow-up. And from a technical point of view, there were high rates of lytic infusion, low IVUS usage, and low stenting rates, again, not reflective of contemporary practice. So what can we gain from the study in terms of benefit to our patient selection? We have to look at the sub-analyses for these. So the first one is PTS prediction. This is one of the most important things when we're considering treating an acute patient. There is a high incidence, but it is all theoretical, and we need to have a better way of defining which patients will develop PTS, and therefore selecting appropriately. So they went back through the cohorts and looked at factors predictive of PTS, and what they found was age, so per year increment, odds ratio of 1. Obesity as well, unsurprisingly. This is a key one, so Valalta score at baseline. So basically the patient is very symptomatic at baseline. Their likelihood of developing PTS is much higher. Employment status, I mean, this is, patients who are unemployed or due to disability at a much higher rate of PTS, but this is subject to lots of confounding variables and I think should be treated with caution. Leg pain severity at day 10, so persistence of symptoms at day 10, so a poor response to initial treatment, again, is predictive of PTS. Now, historically, this wasn't much use to us in the lysis days, but now we have mechanical solutions, waiting to see if a patient at 10 days improves, you can still successfully treat them after this. And again, patients who received rivaroxaban on day 10 following randomization had lower rates of PTS than patients given warfarin. I mean, again, this is all theoretical and early. Rivaroxaban does have some fibrinolytic activity, which warfarin doesn't, so there maybe is something in this, but I don't think this is proven as yet. This is just a slide we do when we're doing talks on patient selection, and I think it reflects quite well how we've incorporated, predictors of PTS. So obviously, phlegmasia, we would only really treat moderate or severe patients, a minimal improvement after conservative therapy. Age, comorbidities, and obesity are all considerations, but not absolute inclusion-exclusion criteria, and you have to be quite pragmatic in your patient selection. And importantly, compliance with anticoagulation and follow-up. Another subanalysis, one of the main criticisms was the inclusion of FemPop DVTs, looking at the iliofemoral subgroup only. And basically at 6, 12, 18, and 24 months, the mean Valalta and VCSS scores were significantly lower in the intervention arm compared with the anticoagulation arm at all time points. And the incidence of moderate or severe PTS, as assessed by a Valalta of greater than 10 or ulceration, was 18% in the intervention arm and 28% in the anticoagulation arm. So even with the headline finding, we can see, looking at the iliofemoral subgroup, there is a benefit in terms of PTS severity and incidence. This is more contemporary data. This is cohort matching. So from the CLOUT registry, which is the Inari-sponsored registry looking at patients treated with mechanical thrombectomy, they went back through the ATTRACT anticoagulation cohort and used 9 covariables, including age, Valalta score, and identified 164 matched pairs. Any PTS was 19% in the CLOUT cohort versus 46% in the ATTRACT anticoagulation cohort, and similarly, a good reduction in moderate severe PTS, and the odds ratio of 3.1, so 3 times more likely to develop PTS with anticoagulation, and in terms of developing moderate or severe PTS, similarly an odds ratio of 3.1. So from all this, what do we know? There are very high rates of PTS with DVT have been confirmed. We have some pretty good tools to help us predict PTS, so age, obesity. The most important ones, I think, are severity of acute symptoms and a poor response to initial anticoagulation treatment. We definitely know there is a benefit for treating iliofemoral DVT patients in terms of reducing severity of PTS, and we also know there's an increased bleeding risk with the use of lytics. So incorporating that into our sort of selection algorithm, who should we treat? So you should only really be treating moderate or severely symptomatic patients. The caveat to that is venous claudication, which is not included in the Valalta score, and it's a very common symptom in young patients. So although they may not have much overt swelling, if they can only walk 50 yards before they have to stop, I would regard that as moderately severe symptoms at least. So we have to be a bit pragmatic in using the Valalta score, but also other tools of assessment. Outside of symptom severity, we need to be more pragmatic in patient selection. So we need to consider the procedural risks and comorbidities, but we have non-lytic solutions now, which obviously reduces procedural risk. I think personally we should be avoiding the use of lytics if possible and going for a primary mechanical approach. And in terms of thrombus distribution, again, this is a relatively controversial topic. We will mainly be treating iliofemoral DVTs because these certainly are more likely to have severe symptoms. However, a number of FemPop patients will definitely develop severe PTS, and we've all seen those. So I think there probably will be a role for treating very symptomatic, moderately or severe symptomatic FemPop DVTs. So we probably should be focusing on severity of symptoms rather than thrombus distribution. That's it. Thank you.